Hey guys, welcome back to Core EM. I'm Anand Swaminathan. This is core content for anyone, anywhere, and just in time. I'm here with one of our PGY4 residents, Ben Cleary.
Hello.
And behind the camera, as always, is Salil Bandari, one of our other faculty members. He's not going to wave to you guys, though. And we're going to do a really quick video looking at the bed-up, head-elevated position for intubation. Now, this is something that Ben reviewed a couple weeks back for us on our EM Journal Update series in our conference. A paper that was in the anesthesia literature looking at this position for intubation and how it improved our ability to intubate. So, Ben, why would we actually do this position? We've been intubating people flat for a long time, and I'll be honest with you, my success rate's pretty good. So why change? Why do this bed-up, head-elevated position?
Yeah, well, the anesthesia literature has shown for years that patients get better pre-oxygenation and longer safe apnea times in the bed-up, head-elevated position when compared to the supine position. Rich Levitan has been talking about this for years. Patients oxygenate better and stay oxygenated longer when standing or sitting compared to lying down because less of the alveoli are dependent. Makes sense. Patients are more comfortable if they're hypoxic when they're sitting up than lying flat. Add to this that with our obese patients, you get that massive tissue off of the chest or abdomen. And finally, some anesthesia literature also shows that you get improved glottic views with direct laryngoscopy in this position compared to supine.
All right, so if we intubate with the patient up, the first thing is the alveoli, less dependent alveoli, so better pre-oxygenation, longer safe apnea time, so we're going to keep those oxygen saturations up higher for longer. We may get a better look at the glottis, according to the anesthesia literature once again, and in our obese patients, we're going to offload some of that mass. So, all right, so let's go ahead and let's demonstrate the actual position. So I'm going to go ahead and hop up on this bed here.
Right, so the patient's going to be in the supine position. The first thing to do is align their head with the head of the bed. So oftentimes you'll have to actually bring the bed into Trendelenburg, and then either the patient will move them up or you can pull up. Once they're in Trendelenburg, you leave them in this position, but then rise the head of the bed to at least 30 degrees. Finally, if you need to, you can get that ear to sternal notch by putting a blanket or towel or something like that right behind the shoulders to really get that alignment you want. And that's it. Takes 15 to 20 seconds. Recommend doing this position during pre-oxygenation and during intubation to prolong that safe apnea time.
Yes, I think it's a simple maneuver. Again, this is anesthesia literature, mostly not emergency literature, that shows that this is a better position for the safe apnea time as well as visualizing the larynx. But I think it's a reasonable thing to try, and if you want to, maybe there's something that you run through in your simulation or with a colleague so you understand the position completely before you do it on an actual patient. It seems pretty straightforward. I think the tips are, again, make sure that, of course, the head of the bed is elevated and that you're still getting that ear to sternal notch to maximize your exposure of the larynx. All right, that's all for Core EM. Thanks, Ben. Thanks, Salil, for doing this. Let us know what you guys think. Let us know if you have any issues, and we'll get you more videos soon enough. Thanks.
Thanks, everyone.